Today our guest speaker is Dr. Kripa Bajaj from Hyderabad. She will be speaking on MPN Connect dose optimization of Jakavi for the treatment of myelofibrosis. This webinar is brought to you by Mumbai Hematology Group. It is supported by Novartis and Nirvin and managed by Perfect Square. I thank Team Novartis and Nirvin, Mr. Yash, Mr. Kalpesh, and the Team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speakers, Dr. Kripa Bajaj from Hyderabad, the first speaker, and Dr. Naseema Gangat from USA, the second speaker. All our discussants are themselves eminent hematologists or medical oncologists. And you participants for sparing your Saturday evening, afternoon, or morning, depending upon which part of the world you belong to. Tomorrow, Sunday morning, 14th of July, from 11:30 a.m. Indian Standard Time, we have Dr. Carbon from Italy speaking to us on Kesselman disease. Our discussions today include a large number of very important personalities from India. Professor Dr. A.K. Tripathi from Lucknow, Dr. Aditi Jain from Delhi, Dr. Aditya Jandial from New Chandigarh, Dr. Aishwarya Raj from Ahmedabad, Dr. Akanksha Salkar from Nagpur, Dr. Ami Patel from Surat, Dr. Ankit Rayani from Ahmedabad, Dr. Ashutosh Panigrahi from Bhubaneswar, Dr. Avinash Kumar Singh from Patna, Dr. Avriti Baveja from Dehradun, Dr. Divya Narayanan from Bangalore, Dr. Madhupriya Borappa from Bangalore, Dr. Madhura Tineka Deshpande from Pune, Dr. Pratibha Singh from Vadodara, Dr. Priya Darshani Peram from Bhubaneswar, Dr. Siddharth Shankar Ray from Kolkata, Dr. Vishnu Sharma from Jaipur, and Dr. Yoga Lakshmi from Hyderabad. Dr. Kripa Bajaj, all of you know her well. She has been our speaker at multiple occasions in the last 4 years. She's been very active participant in the webs. She's consultant medical oncologist at KIMS Hospital, Hyderabad. Her work experience includes internship at Government General Hospital, Guntur, AP, post-graduation in internal medicine from Government General Hospital, Guntur, residency in medical oncology at Tata Memorial Hospital, Mumbai from 2017 to 20, assistant professor at Tata Memorial Hospital, Mumbai 2021, instrumental in establishing genetic clinical services at BIA CHRI at Hyderabad. Her academic achievements include gold medal in internal medicine, Guntur Medical College, Guntur. She presented rare cases of NUT carcinoma and rectal granulocytic sarcoma at ESMO Asia 2019, Singapore. Project selected for discussion at Accord, Australia. Presented poster at SABCS 2020 Virtual Symposium, TNBC Maintenance Chemotherapy. Today she will speak on MPN Connect dose optimization of Jakavi for the treatment of myelofibrosis. Thank you, and over to her. I will just log out.
Thank you, MB Agarwal sir, for such a kind introduction and also encouraging all of us to learn a lot of things and to speak and study regarding hematological updates and everything. Today, I'm going to discuss regarding a nuanced topic, that's a MPN. So all of us do have seen cases like how we are managing, and a lot of lapses in the knowledge is there. So all of us used to have a lot of discussion during our residency how to manage it. So now the discussion is going regarding the dose optimization of ruxolitinib for treatment of myelofibrosis. The table of contents, like what I'm going to study is, all of us know the two types of presentations are either anemic thrombocytopenic or splenomegaly. Now I'm going to discuss regarding how we treat thrombocytopenia patients in myelofibrosis as per 3 studies. and also how we treat anemic patients, the dosage of ruxolitinib in these patients. A brief introduction regarding ruxolitinib for treatment of myelofibrosis. So all of us know ruxolitinib dose is based on the patient's platelet count during the initiation of therapy, and less than 50,000, it's not recommended to start ruxolitinib. 50 to 75,000, 5 mg BD, 75,000 to 1 lakh, it's 10 mg BD, 1 lakh to 2 lakh, it's 15 mg BD, and more than 2 lakh, it is 20 mg BD. In phase 3 comfort studies, the starting doses were based on the proper platelet count of the patient's baseline count. So 1 lakh to 2 lakh, more than 2 lakh, likewise, I just mentioned, it will be decided based on the patient baseline count. The starting dose for 5200 in JUMP and study 258 was 5 mg BD. And practically most of us do also start with this, unless patient is like really affordable for that, like most of us do start with 5 mg BD, which is a practical dose to us. No trial has evaluated platelet count less than 50,000 to start ruxolitinib. Hence, no one is like recommended less than 50,000 not to start it. And also over the course of treatment, the dose of ruxolitinib is titrated for the each patient. It's not that each patient will get the same dose. We do see the efficacy. We do start with the 5 mg BD, and also we do titrate, and the maximum dose will go up to 25 mg BD if platelets and neutrophils counts are adequate. Is it really required to titrate the dose? It's okay to start to continue the dose what patient is tolerating will be discussed further. The starting dose should not be increased within the first 4 weeks. Whatever the dose we started with, the 4 weeks we just do it with the stable counts and everything, and later we will step up the dose. It's not more frequently, more than like 2 week interval. So we do precisely 2 weeks, like we do give a gap actually. So the initial dose definitely 4 weeks we do watch. In order to optimize treatment with ruxolitinib, patients should maintain their highest tolerated dose for the maximal efficacy. So this part is very important. Though most of the patients are comfortable using 5 mg BD as per the financial constraints, is it really worth to titrate the dose or not is a question. The maximal tolerated dose is the best dose to use it to optimize the efficacy. This slide will describe the recommendations for ruxolitinib dosing and how it is optimized through the course of MF treatment. Patients' platelets more than 1 lakh at the start of the treatment, and patients who are having 50 to 1 lakh dose, what is the start? So here I'm going to discuss regarding a patient who got detected with the myelofibrosis and the platelet count is more than 1 lakh. What are the studies and what is the outcome? So the comfort study, it says the ruxolitinib dosing profile doses over the time. The experience from the comfort study suggests that most patients treated with ruxolitinib will be able to tolerate more than 10 mg PD. It's not 5 mg PD, like even the Indian setting, we do start with 5 mg BD, we step up, like most of patients comfortable tolerating the highest dose. Me, for myself, I have a patient who is tolerating 20 mg BD comfortably without any issues. 25 mg, 4 of my patients, I'm keeping 20 mg BD, 15 mg BD as per the tolerance. I didn't go beyond 20 because of a lot of reasons, because of thrombocythemia where they're having. In Comfort 1, the majority of patients originally got randomized to 15 mg versus 20 mg BD, had their doses titrated by week 24 to a mean dose of more than 10 mg BD, which remains stable with long-term therapy. If you see here, there's a 20 mg BD dose as curve, as well as this is a 15 mg BD dose curve. Why we have to titrate? What are the benefits of higher doses efficacy by final titrate dose of ruxolitinib? The larger improvements in spleen volume and symptoms. So in myelofibrosis patients, it's not just the fatigue or the lab value of low platelet count. Most of them splenomegaly will cause a lot of discomfort. So patients who got a higher dose, that's a more than 10 mg BD dose, compared with those who received lower doses, will have a greater efficacy observed at more higher doses. So if patient is going up to 25 mg, the spleen volume, the cytokine TSS, everything got resolved. In Comfort 1, the improvements in spleen volume and symptoms were observed in ruxolitinib treated patients who received a titrated dose of less than 5 mg BD, but doses are more than 10 mg BD. So here, more than 10 mg BD patients are doing really well. The benefits of higher doses, spleen size reduction and overall survival as well. Not just symptoms, there is an overall survival benefit with the maximal dose. Large reductions in spleen volume with the ruxolitinib treatment has been associated with prolonged overall survival. If you see the curves are heading towards a higher dose. The correlation of the spleen volume reductions at week 24 with overall survival. It indirectly says that higher doses will lead to good splenic volume reductions. Good splenic volume reductions at week 24 correlates with the good overall survival benefit. In comfort studies, patients who achieved a more than 10% reduction in spleen volume from baseline at week 24 had a better prognosis compared with the patients in the less than 10% reduction category. So as we step up the dose, like just now I mentioned at week 24, if the spleen volume reductions are adequate, the overall survival got affected, and the patients with better spleen reductions will have better survival. So with the increase of dose, what are the adverse effects noted and how will manage the adverse events? So most of us do encounter with the penias because ruxolitinib is a potent JAK-STAT pathway inhibitor. Some myelosuppression, including anemia and thrombocytopenia, was anticipated. In the phase 3 comfort study, anemia is in 82.4, thrombocytopenia is in 69.8, and neutropenia is in 15.6. So all these are dose-related side effects. Cytopenias occurred in this comfort studies were successfully managed with dose reductions and RBC transfusions. Though there is an anemia incidence is there, we'll titrate the dose. Like most of the patients received more than 10 mg BD. I did mention before that my patient doing the highest dose what I am using till now is 20 mg BD for one patient, but most of the patients they're using 15 mg, 10 mg likewise. 25 mg I never touched till now, but there's a maximum tolerated dose like what they says. The better the tolerance, like we step up the dose higher. But practically with the dose titration, if 20 mg is not feasible, then we'll down titrate 15 mg up to 10 mg. Sometimes we go to 5 as well, but like very few patients do go that. So with simple titration, the T half is less for the TK, and the patients are used to have a bouncing of the hemoglobin or platelets to normalcy. So the management of anemia, the hemoglobin levels over time, it's a predictable decrease in hemoglobin often occurs during first 12 weeks of ruxolitinib treatment, but hemoglobin levels typically recover to near baseline levels after 24 weeks of treatment. Just initial 12 weeks, just not to get affected. Eventually, it will get normalized. Once things are getting settled down, maybe you can step up the dose or you can just maintain the stable dose if the drop is not significant. So initial dose intensity should be maintained to a predictable and temporary decrease in hemoglobin during the first few weeks should not affect, except it is really significant. And with a simple introduction of the supportive care, that can be managed well. So the impact of anemia and impact of hemoglobin on overall survival. In an analysis of the comfort data sets, the survival observed in the ruxolitinib group was consistently better than survival observed in the control group, irrespective of the hemoglobin change at week 12. So if you see the ruxolitinib drop less than 3 grams and more than 3 grams control and everything. So the hemoglobin decrease that occurs on treatment do not adversely affect the ruxolitinib related benefit in overall survival. So unless the patient is symptomatic, we don't usually transfuse. So more than 8, it is fine to manage. Patient usually will not have any symptoms. If patient is having symptoms, then better to titrate it. Till 24 weeks, it's with simple supportive therapy, it can be managed most of the times. If it is really significant, then definitely we have to down titrate the dose. But if not, patient is not symptomatic, it's okay to continue the same and slowly the negative effect will be weaned off at 24th week. Ruxolitinib treatment appears to dilute the negative prognostic effect of lower baseline hemoglobin levels on survival because it's just a treatment-related effect. So the analysis and comfort study shows that hemoglobin changes that occur with ruxolitinib therapy may not bear the same prognostic implications as those occur as a consequence of MF pathology because it's a simple treatment-related side effect. What about thrombocytopenia? What about platelet counts over a time? After an initial decrease with ruxolitinib treatment, mean platelets remain stable over the long-term treatment. So if you see here, the placebo as well as ruxolitinib, like once it got it's a week 12 and later week 24, and by and large, the curve remains the same without any drastic decrease. So management of thrombocytopenia platelet counts over time by dose. The mandatory dose reductions and treatment interruptions were associated with stabilization of platelet counts after first 8 to 12 weeks of treatment. So the conclusion here is still 12 weeks, the decrease is there not to jitter, and up to 24 weeks also you can just continue the treatment and see. In comfort one, only one patient with ruxolitinib group discontinued due to thrombocytopenia. Otherwise, not other patients got affected with the thrombocytopenia. So post 12 weeks, by and large, the platelet count is going to be stabilized, and for hemoglobin post 24 weeks, it's going to get stabilized. The dose modifications based on safety and dose reduction should be considered if platelet counts decrease as outlined below. Just I mentioned before in the very beginning, less than 50, yes, absolutely you have to hold. 50 to 75 mg BD is like fine. 75 to 100 mg BD. And if you're starting like, if you're just like down titrating the new dose and all like this table, you can just change. You can just down titrate the dose. So 100 to 125, you can just step down one, like 25, the new dose will be 25 to 20 and 20 to 15 likewise. So if you see the starting dose, it is 25. There is a drop to this level, just step down to 20. If the drop to this level, that's 75 to 1000, 75 to 1 lakh, so you can make it 10 mg BD. If it is 50 to 75, you can make it 5 mg BD. So this is your starting dose. If after starting the dose, after a few weeks, if you recount the CBC, if there is a slash of the count to this level, you can come down to this level. So this is the one ideally you can follow. Treatment should be discontinued for platelets less than 50,000 or ANC less than 500 at any cost. There should not be any down titration. So irrespective of the dose you are using, if it is less than 50,000, you have to hold, and ANC less than 500, you have to hold. So 5 mg, so here 5 mg up to 75, up to 50, there is no need to change at all. But here, as the dose you are stepping up, there is a slump in the count. You have to follow this table for a new dose management. So stopping ruxolitinib treatment, symptoms return to baseline level. So patients who had an interruption of ruxolitinib experienced a return of symptoms to baseline levels within approximately 1 week. So if you stop like within 1 week, the previous symptoms and everything do reappear. The return of symptoms may be expected after discontinuation of an effective therapy. So it is important to note that upon reinitiation of ruxolitinib, the total symptom score improved again to levels similar to those before dose interruption. So it is important to note that with the stoppage of the treatment, within 1 week, the patient do resume to previous symptoms. And with initiation, again, there is a normalcy of the symptoms. So this is a total symptom score before and during dose interruption. If you see this, interrupting the dose will cause a significant slump. Ruxolitinib for treatment of patients with the myelofibrosis and thrombocytopenia. In this one, study 258, expand and jump. These three studies are very important. The previous one, what we discussed was regarding the comfort trial. So here, MF and thrombocytopenia, ruxolitinib for treatment of patients with MF and thrombocytopenia, comfort studies required baseline platelet counts more than 1 lakh. It limiting the available of safety efficacy data in patients with a lower platelet count. However, thrombocytopenia is frequent in myelofibrosis. So most of us do see a significant platelet crash in the myelofibrosis patient. The ideal patient only will have more than 1 lakh. There are currently three clinical trials evaluating the use of ruxolitinib for treatment of patients with a low platelet count. Study 258 expand. This is the phase 2 clinical trials. In this, ruxolitinib was evaluated in patients who are having a counts 50,000 to 1 lakh. The study 258 is evaluating a starting dose of 5 mg BD with intra-patient dose escalation. Expand is evaluating different starting doses. The jump is nothing but a JAK inhibitor ruxolitinib in myelofibrosis patient is a phase 3B expanded access trial that was amended to enroll patients with platelet count baseline more than 50,000. If you see these studies, comfort is more than 1 lakh, but all these three studies, they enroll a patient who are having more than 50,000 baseline platelet count. This section will describe safety and efficacy in patients who are having a low platelet count. The study 250 is a very well designed study, though it's a phase 2 study. It's a 24-week open label phase 2 study, which evaluated the safety and efficacy in 5 mg BD starting dose with subsequent intra-patient dose escalation for patients with low platelet count, how we do manage in patients who are having a low platelet count. So here, all patients do begin with 5 mg BD. All doses increases are optional. So if it's a 5 mg BD, eventually you make it 15 and later 10 mg BD, that's 20 per day. Later is 10 mg and 15 mg, 15 mg BD. So that's how it got titrated. In addition to adequate platelet and ANC, further dose increases above 10 mg BD require patient global impression of change. That is PGIC score of 3, minimally improved, or to 7, very much worse. So what is the distribution of ruxolitinib dose over time? In patients who complete 24 weeks of treatment, the majority had optimized the ruxolitinib dose to 10 mg BD or higher. So there is no contraindication like to start patients who are having a low platelet count if it is more than 50,000. You can eventually titrate as per the patient response and tolerance. If you see here, most of the patients are tolerating a dose more than 10 mg BD, which we discussed in comfort trial. Patients who are maintaining a dose more than 10 mg BD, they're having a good outcome, beta spleen response rates, beta overall survival. The change in symptoms and spleen volume at week 24 is significantly better. So 20% had more than 35% reduction in spleen volume, and 34% had more than 50% improvement in total symptom score. The median reductions of spleen volume and the total symptom score at week 24 were 24.2% and 43.8% respectively. The changes in symptoms and spleen length, and again I say this, the patients who are having a baseline count between 50,000 to 1 lakh, the starting dose of 5 mg BD and titration to 10 mg BD resulted in spleen reductions and improvement in symptoms that were consistent with those in patients with higher platelet count. The changes in URTC QLC QLQ-C30 subscales at week 24, that's a global health status quality of life score. So 5 functional domains and individual symptom scale got improved with the ruxolitinib. That's a fatigue, pain, nausea, vomiting, dyspnea. And also URTC QLQ C30, that the global status are QL, physical, emotional, cognitive, social, all functional domains got improved. So apart from these aspects, all functional domains got improved. In the summary of non-hematological adverse events. So there is a grade 3, grade 4 events are really less, but other grade events are like manageable one. The new onset hematological adverse events, again, grade 3, grade 4, the anemia as well as thrombocytopenia, if you see grade 3, grade 4 is significant, but still with the dose titrations, it can be managed. All grades in grade 3, grade 4, if you see, it's almost like nearly 2/3, I would say, which can be easily managed with a dose titration. The changes in platelet counts in study 28 and comfort 1, if you see, the mean percentage change in platelet counts were comparable in ruxolitinib treated patients in study 258 and placebo treated patients in comfort 1. The changes in hemoglobin patients without transfusions, decrease in hemoglobin levels in study 258 were of lesser magnitude than patients receiving ruxolitinib and similar to those patients who received placebo in comfort 1. So they're just comparing the low dose, low platelet count as well as comfort 1 placebo. It's not really significant. So the low platelet JUMP study, if you see, JUMP is a phase 3B. So sorry, I just want to conclude the study to fit, which is a beautifully done study. And in this one, though it's a phase 2, it finalized that the patient, it's okay to start 5 mg in patients who are having a low platelet count. That's a 52 more than 50,000, though it's less than 1 lakh. It's okay to start. Not like comfort study. There is some degree of anemias are there, but still those are comparable to the placebo arm of the comfort study. Be it thrombocytopenias, be it anemias or its transfusions, it's comparable to the comfort placebo arm. So study 250 established that it's good to start 5 mg BD in patients who are having a low platelet count with a manageable tolerance. So JUMP, again, it's a low platelet cohort. If you see here, JUMP is a phase 3 expanded access trial for patients in countries with no access to ruxolitinib outside of the clinical trial. The starting dose, again, here it is 5 mg BD. That's again 50,000 to 1 lakh. And interim analysis of the safety and efficacy of ruxolitinib in patients with a low platelet count got analyzed. Here, the PMF, PPVMF, as well as PET-MF, high to intermediate 2 risk patients got enrolled. The treatment, the baseline count just I mentioned before, 50 to 1 lakh 5 mg BD, 1 lakh to 2 lakh it's 15 mg BD, more than 2 lakh it is 20 mg BD for 24 months are commercially available drug. It's predominantly done in the low income or middle income countries. The median dose daily was 11.8 mg per day. The investigator determined that dose escalation from starting dose of 5 to 10 mg BD was needed in 18.4 patients. The safety, if you see the hematological adverse events, the common adverse events were thrombocytopenia. The grade 3, grade 4 went up to 30%, and anemia is grade 3, grade 4 is 28%, which is slightly less. Only 6% patient discontinued due to thrombocytopenia. In comfort, only 1 patient discontinued. But here it is 6% patient who got discontinued. which is reasonable as patients' baseline platelet count is just 50,000 to 1 lakh. The non-hematological toxicity is also very low overall, and with only just exceptional pyrexia, septic shock, very few patients got there. So the efficacy, if you see again, the spleen volume as well as symptom responses observed in this low platelet cohort were within the expected range compared to phase 3 comfort. If you see the spleen length or the FACLIM score, it is meaningful symptom benefit as well as spleen reductions got noted, which directly or indirectly correlates with the overall survival benefit. The low platelet cohort as well as overall GEM population, if you see, although there are important differences between the patient populations that may lead to different outcomes, the rate of responses observed in overall GEM population were higher than those observed in low platelet cohort, which may be explained by difference in doses that platelet received. And again, expand. Expand is like we see here, there's an expand, it's an open label phase 1 dose finding study. It's just a dose finding study in adult patients with PMF, PPV, MF, PET-MF with a baseline count 50,000 to 1 lakh. The study reports safety of Ruxolitinib from expanded treatment protocol study at week 96 data cutoff. So the criteria, the median exposure, I'll just go step by step. In this one, it's just on a dose expanded study. If you see the stratum 1, stratum 2, here it is 75,000 to 1 lakh. And here the stratum 2, the baseline platelet count is 50,000 to 75,000. So 50,000 to 75,000, 75 to 1 lakh. How we are going to forward? Here, 5 mg BD and again 15 mg like per day, dose 2, like this, the total iteration has had happened. Here, if you see 5 mg BD and again this was done. But the dose escalation phase here is like slightly rampant compared to this. So what are the findings from EXPAND study in myelofibrosis patients with low platelet count? And it supported the use of 10 mg BD as a starting dose of Ruxolitinib in S1. That is, stratum 1 is 75,000 to 1 lakh, but were less conclusive for stratum 2. But stratum 1, like not just like a blanket 50 to 1 lakh, we have to start with 5 mg BD. The EXPAND study said that 75,000 above, 75,000 to 1 lakh, we can start with 10 mg BD. Ruxolitinib was very well tolerated at all doses and provided spleen size reduction and symptom response benefit. Further evaluations to confirm the safety and efficacy of Ruxolitinib will be performed at the end of the ongoing study. And when it comes to anemia, there is only one study like I'm going to discuss, that's a realized study. So here the conclusion is with overall all the discussion, 50,000 to 1 lakh is the one which always have a lot of ambiguity. More than 1 lakh, there is not much discussion is that we just do start with the low dose and we just slowly up titrate it. In that more than 1 lakh, it's okay like to start with 10 mg BD, we just like jump up to maximum up to 25 mg BD. But 75,000 to 1 lakh, better to start with 10 mg BD straight away, not to hesitate whether to start or not. 50,000 to 75,000, good to start with 5 mg BD as per the previous trial. Expand trial, though it established that more than 75,000, it's good to start with 10 mg BD, but 75 and between 50 to 75, the outcome is less conclusive to say this dose is like tolerated well. But with the previous experience with 5 mg BD, whatever adverse events are there, they are very much manageable one with a down titration of the dose. How to down titrate the dose, I discussed with the previous slide. Thus, the table is really important and very good to use in most of our practices table. When the platelet count got decreased, what is the dose patient is using, how to decrease, like what is the slump in the platelet count we have to see, as per that we have to adjust. The last one is regarding the anemia, that's a realized trial. So what is the realized trial study design? So in this one, less than 10 gram is the cutoff, the anemia cutoff. So it's a multi-center phase 2 open label single arm study. And this one, splenomegaly more than 5 centimeters, hemoglobin less than 10 gram per deciliter, platelet count more than 50,000 got included. Here, platelet count, if you see it's a more than 50,000, it's like 5 to get included. The treatment dosing is 10 mg BD. The up titration based on efficacy and safety up to 25 mg BD. It's a single arm study. The evaluation, the primary endpoint is proportion of patients achieving more than 50% reduction in spleen length at week 24. Secondary endpoints are transfusion requirements and dependence over time, safety, and adverse events. So the endpoints were assessed by transfusion dependence, defined as patients receiving more than 6 transfusion units in 12 weeks prior to assessment. The efficacy, more than 50% spleen length reduction got noted in 56% of patients. 25 to 50% spleen length reduction is 11.4% patient. 70% of patients achieved a more than 50% reduction in spleen length at any time during the study. Spleen length response at week 24, that is 5 by 9 of intermediate 1 and 16 by 28 of intermediate 2 and 4 by 10 of high risk patients showed more than 50% reduction in spleen length, which is significant. So the majority of patients experience a very good reduction in splenic length. The patient-related outcomes, if you see, 77.8% of patients reported an improvement in PGAC, which I discussed before, at week 60, with the 3 patients reporting no change and 1 patient reporting a minimally worse assessment. So if you see, 77.8% had improved PGIC at week 60, which is significant. The patient symptomatic benefit is really good. What is the safety when patient got introduced in less than 10 hemoglobin, whether to introduce or not? Is it really patient really tolerate well or not? So 86.3% of all patients reported adverse events. So 50% were considered treatment related and the rest are not. So eight patients got died. Out of 8, 7 were with infections and infestations, cardiac failure, multiple organ dysfunction syndrome and everything. Neutropenia is there, but it's not really significant. But most of the patients do have a lot of thrombocytopenia and anemia. The neutropenia component is like less. So median hemoglobin levels remains reasonably constant throughout with the support of RBC transfusions. So RBC transfusion requirements for TD and non-TD patients also remain fairly constant throughout the study. So the key points are the recommended with this relay study. So though it's okay to start patients with less than 10 hemoglobin, it's good to start with patients like more than 50,000 platelet count. So no need to hesitate, and we can down titrate the patient's dose if it is like patient is having a significant side effects. Any great adverse events, we can down titrate immediately. And with the decrease in dose, I just mentioned before, within a week, patient do have a better responses in the sense there is a resumption of the improvement in platelet count or anemia, whatever. If you stop, the patient will have a symptomatic worsening within 1 week. If you start, again, patients will have a symptomatic improvement within 1 week. So TK, as its half-life is just only 48 hours, drastic improvements will be there if we start the patient, and also we can down titrate immediately with a good benefit. So the key points of today's discussion is the recommended starting dose of ruxolitinib is based on patient's platelet count at the initiation of therapy. I just mentioned before, more than 50,000, 50,000 to 75,000, 75,000 to 1 lakh, 1 lakh to 2 lakh, and more than 2 lakh. Likewise, you have to choose. In order to optimize treatment with ruxolitinib, patients should maintain the highest tolerated doses for the maximal efficacy. I mentioned before, the spleen length reduction at week 24 is going to be a prognostic factor for the overall survival. So better response rates were observed for patients with the more than 1 lakh who received doses 10 mg BD. For patients with a platelet count of 50 to 1 lakh, start with the 5 mg BD. And I mentioned before, more than 75,000, you can start with 10 mg BD, which resulted in spleen volume reductions and improvement in symptoms that were consistent with those patients with higher platelet count. Improvement in spleen size and symptoms were observed in patients with a low platelet count who were receiving 5 mg BD maintenance dose also. So it's not that if you use higher dose only patient will get response. 5 mg BD is also good to continue. Dose titration is a key element in the management of dose-dependent cytopenias associated with the ruxolitinib therapy. With the goal of avoiding dose interruptions for thrombocytopenia, some patients may require dose titrations for decreased platelet count, especially within first 12 weeks of therapy. Initial dose intensity should be maintained during a predictable and temporary decrease in hemoglobin during first 12 weeks of ruxolitinib is noted. Thereby, by introducing supportive care such as RBC transfusions, we can maintain the same dose. Post 24 week, it's going to get stabilized for hemoglobin, and post 12 weeks, it's going to get stabilized for platelet count. So this is what are the indications what we use is intermediate or high risk myelofibrosis. The dose is 20 mg BD in patients with platelets more than 2 lakh. The maximum dose what we can give is 25 mg BD and 15 mg BD in patients with platelet count 100 to 1 lakh to 2 lakh. So the efficacy is the spleen volume reductions. So 42% of patients had more than 35% spleen volume reductions at 24 weeks or later. The median duration of spleen response was 3.2 years. The symptom reduction, 46% of patients had more than 50% reduction in total symptom score at week 24. Safety, anemia, that's more than grade 3 is 45%. Thrombocytopenia more than grade 3 is 13%. Hepatic toxicity, that's transaminases is noted in 27% and 18%. Infections risk is 38%. I mentioned before, patients do lost with sepsis. And the price is 35K per month. It's for Novartis information. I'm just sharing this. There is a patient assistance program also got noted. With this, I conclude my talk. Thanks for the patient hearing, and thanks to MBA Agarwal sir once again for giving this opportunity. I'm happy to learn from you and happy to take any questions regarding myelofibrosis management.
Thank you, Dr. Kripa, for that beautiful talk and giving the guidelines about dosing of this important drug in patients of myelofibrosis. There were a number of gray areas. There used to be a lot of questions. And I think this talk will be extremely helpful to all those who have logged in today to listen to you. We do have about 4 minutes if there are questions from our faculty present here, discussants. In the chat box, there are no questions at the moment, but audience who are logged in from all over, if you have any question, you can put in the chat box. Right. Dr. Yogalakshmi, your question.
Thank you for the excellent presentation, ma'am. And sir, thank you for the opportunity which you have given always and supported always in this academic events. Ma'am, when should we stop ruxolitinib before allo transplant? And is there any ideal time which we have to stop, and whether we have to taper and stop or
stop right?
Suddenly?
So right, I mean, as of now, I mean, I'm just stopping 2 weeks before because we know the TK washout will be only just a 48 hours. So continuation of TK, I don't see any undue significant side effects during allotransplantation. So as of now, we are just stopping 2 weeks before because the decompensation again symptoms will be worse for the patients. I would like to take opinion of MBA Agarwal sir as with the high volume cases of MF in the country. So what's your opinion, sir, regarding this?
No, that's fine, Kripa. We have very short time left. You got 2
Yeah,
minutes.
sir. Sure.
Madhupriya, your question.
Good evening, ma'am. Thank you for the talk. And I just had one quick question. Will the mutation profile, especially in triple negative MF, have any effect on the response to ruxolitinib? The second is time permits. Ruxolitinib experience in autoimmune myelofibrosis. Thank you.
So the second question, I recently had one patient who is like autoimmune disorder with MF. The patient have significant cytopenias. So I had to downgrade the dose very significantly. I'm just like using only 5 mg BD for her. In spite of that, she's having a lot of breaks in the treatment with a lot of supportive care. The first one, triple negative one, yes, obviously the patient is prognostically, we know that, but there is nothing related to ruxolitinib as such now. The responses were like decent enough, only the prognostic aspect got changed.
Thank you, ma'am.
You prepare one last question. Dr. Meenakshi has put a question in the chat box. How long is Jakavi advisable for patients who are beyond the age of 70?
As of now, like we are continuing just indefinitely. We are not stopping, ma'am, unless patient is intervening with the transplantation or something. There is no as such guideline to stop after this period.
All right. Thank you so much, Dr.
Thank you so much, sir. Thank you, sir.
And I see Dr. Nasima Gangat has already logged in. Thank you so much, Dr. Nasima, to be with us this evening. I will just share my screen to introduce her. So I don't think the audience over here today need her introduction. She has been our regular faculty and has educated all of us, whether we are from India or rest of the world, who have logged in to listen to her. Almost every 3 to 4 months, she has been our faculty for last 3 to 4 years. And we've learned a lot in the field of myeloproliferative neoplasm from her experience and her talks. To complete the formalities of introducing her, today she's going to speak to us on ET, Prognostic and Therapeutic Approach in 2024. So this is just the formality that I'm completing in a very brief introduction of hers. She's Professor of Medicine in Division of Hematology at the prestigious Mayo Clinic, Rochester, Minnesota. She received her medical degree from Aga Khan University, Karachi. This was followed by internal medicine and hematology training at the Mayo Clinic itself. And then she joined the Mayo Clinic as a faculty in 2012. She currently serves as the Education Chair, Division of Hematology, and Program Director for the Advanced Hematology Fellowship Program. She was named Teacher of the Year by the Hematology Fellows in 2016, 2020, and 2021. Her clinical and research interests are focused on myeloproliferative neoplasms, and all of us have been reading all her publications to learn something in this field. She has authored and co-authored over 100 papers, and this may be much more. This is a little old bio sketch that I have of hers. Her key contributions to the myeloproliferative neoplasm field include improving prognostication, investigating and connection between mutations and clinical phenotype, and evaluating novel therapeutics. She has served as editor-in-chief of the American Society of Hematology News Daily 2021. She is currently associate editor for Blood Cancer Journal and editorial board member of the American Journal of Hematology. As I said earlier, today she is going to speak to us on essential thrombocythemia, prognostic and therapeutic approach in 2024. I'll stop sharing and request her to speak to us.
Hi, good evening, everyone. Thank you for joining. I know it takes a lot to spend your weekends listening to a lecture, so we're going to go ahead and get started, and hopefully I can get this to work. Let's see. Is the screen looking okay on your end? Because I can never tell if I'm on the right side.
Yeah,
Do I need to?
You only make full screen.
Is that better?
That's perfect.
Okay, perfect. So we're going to go ahead and get started. In the next 40 to 45 minutes, we'll go through essential thrombocythemia. I had the pleasure of logging in earlier, and I know there was a nice presentation on myelofibrosis. So this is going to be all related in terms of the evening discussion. So there are a few of my disclosures, nothing relevant to ET, but it's good to kind of look through them. I will go through the diagnostic approach because ET is very close to a related disease called prefibrotic myelofibrosis, and that impacts prognosis. So hence I did put in a little bit of information on the diagnosis on how to distinguish between the two entities. We'll walk through prognosis, particularly in light of more molecular information being known over the years, and then go through a newer survival prognostic score, the AAA score, which incorporates age, absolute neutrophil count, and absolute lymphocyte count, and is more like globally applicable and would be applicable to patients in any region without access to molecular testing. And I will spend a few minutes on some of the newer therapeutic approaches, particularly in terms of the mutant CALR antibody-based therapy, which is very exciting since as of now, there's no treatment in ET that has been curative in nature. And then there's new data on the use of aspirin twice daily, as opposed to once daily in patients with ET. So we'll kind of walk through each of these sections. So as far as the diagnosis, I think this audience may be familiar from the prior lecture as well, that these are all related diseases, the myeloproliferative neoplasms. There's polycythemia vera, there's essential thrombocythemia, and myelofibrosis. And in myelofibrosis, there are two entities, an early entity called prefibrotic MF, and there's an overtly fibrotic MF. So the discussion today is going to focus on ET, but because we often come across cases which could be nuanced, For example, in ET, patients could have a high hemoglobin. So the question is, do you call that ET or do you call that PV? And then similarly, if somebody is a little bit on the anemic side, has a high LDH and dacrocytes, do you call that prefibrotic MF or do you call that ET if the platelets are high? So hence, it's good to kind of know the schema and the spectrum of diseases. And there is significant overlap even over the course of a patient's disease. They could start with ET and then kind of transform into one form or the other over time. So I think it's important to kind of review the driver mutation profile in ET. The majority of the patients harbor the JAK2 V617F mutation, which is present in 2/3 of cases. The ones who do not, we reflex to the CALR mutation testing, which a quarter of patients will harbor. And then MPL mutations are quite infrequent, about 3% of ET patients. And in fact, whenever we come across a case of MPL mutated ET, it's good to go to the drawing board and make sure they don't have myelofibrosis because it's not a very common mutation in ET. And we do know that MPL mutated ET does have a higher risk of progression to myelofibrosis, suggesting that it may be on that end of the spectrum, like prefibrotic MF. And then there are triple negative cases, about 8 to 10% of ET patients. When you run the molecular profile, they don't have any mutations. And those are tricky because it often becomes a little bit difficult to tease apart. Does that really, is it clonal thrombocytosis or it is a case of reactive? And we label them as triple negative, particularly if their bone marrow changes, suggestive of a myeloproliferative neoplasm. So just kind of walk through the diagnostic criteria. We start off with the mutational profiling, which can be done on the peripheral blood. So if the mutation is present, that tells you there's an MPN, but it wouldn't tell you which specific kind of MPN. Hence, a bone marrow biopsy is needed to kind of establish the diagnosis, presuming you've ruled out all the reactive causes of thrombocytosis, iron deficiency, inflammation, post-splenectomy state, and all the easy stuff. And then, of course, the morphology will lend us the distinction between ET versus prefibrotic myelofibrosis. And I did put in the criteria for prefibrotic MF since it's a close contender. These are also patients who present with high platelet counts, but they will have some degree of fibrosis in the marrow. There may be anemia, leukocytosis, splenomegaly, which is palpable, and LDH above the reference range. So some of these cues may kind of tell you that your patient may be having more of a prefibrotic MF picture as opposed to ET. And then this is a really nice slide, which kind of goes to the distinction between the MEGs in patients with ET versus prefibrotic MF. So in ET, we expect the megakaryocytes to form loose clusters. They're large and mature, and in prefibrotic, they're more tight. So this may be, so if there's an astute pathologist, they could help us with the distinction as well. So why is this important? Since my lecture is focused more on prognostic and therapies, it is important because the prognosis of patients with prefibrotic MF and ET is distinct. The survival of patients with prefibrotic MF is slightly inferior compared to patients with ET. Similarly, leukemic and fibrotic transformation rates are higher. And while thrombosis rates are similar, so the management in terms of the practicalities, it doesn't differ. You would advise thrombotic risk reduction for the prefibrotic MF patients like we do for the ET patients. So here we kind of compare the survival. Prefibrotic MF is in the black curve, ET is in blue, and the general population in Europe is in yellow, suggesting that ET and the general population is quite similar, even though not completely the same. The life expectancy in ET is slightly below the normal life expectancy, whereas prefibrotic MF is much inferior compared to them. So let's just kind of dive into prognosis, since there's a lot of information that has evolved specifically over the last couple of years. So this is kind of a more of a general slide, which kind of compares ET, PV, and myelofibrosis, suggesting that if you took all patients with ET, the median survival is close to 2 decades, about 18 years. Similarly, the leukemic transformation rate in ET is fairly low, like about less than 5%, less than 3%. Fibrotic transformation is about 15% or so. And thrombosis is kind of the main problem that these patients suffer from, both arterial and venous events. And the incidence rates can be as high as about 20 to 25% in these patients. But the important thing to know is that the survival is all dependent on the patient's age. For example, if you took somebody who's 40 years old or younger, their survival is going to span many more decades compared to somebody who's 70 years old. So when we stratify the survival for these patients by age categories, you can see here that patients who have ET and who are less than 40 years of age, the median survival is about 37 years, suggesting it's almost close to 4 decades. As opposed to if you're above 60 years of age, then the median survival is about 10 years, a decade, which is kind of a known entity because there are many competing factors for death in the older patients. So how do the driver mutations impact prognosis? So I know this is a little bit of a busy slide, but I'm going to walk you through these panels. The one that I'm pointing out is the one for overall survival. So patients with the JAK2 mutation, as opposed to patients with CALR mutations, specifically the type 1 CALR, they have a shortened survival. And I didn't go through the types of CALR mutations, but maybe this is a good place where I can. The type 1 CALR mutation is the 52 base pair deletion, and the type 2 CALR mutation is the 5 base pair insertion. So whenever we get the reports that a patient is CALR mutated, we like to kind of tease it apart whether it's a type 1 or a type 2, because there are slight differences in their presentation as well as prognosis. So that is one thing to remember, is that the patients with JAK2, they had median survival of about 17.8 years, as opposed to CALR mutated patients where it was about 22 years. And the triple negative patients actually have the best survival, up to about 25 years median survival, suggesting that it's hard to know. Some of those patients may actually have not been true ET cases, but they got labeled as triple negative ET because there was no other explanation for their thrombocytosis, even though the mutation profile was, with the mutation profile being negative. The leukemia-free survival was no different based on the driver mutations. And then the important thing to point out is the myelofibrosis-free survival is also distinct based on the driver mutation profile. Patients with type 1 CALR mutation have shorter myelofibrosis-free survival as opposed to JAK2. And the MPL mutated patients, there were 30 cases in a very large data set, suggesting that some of those patients, even though they've been curated and were felt to have ET, may have had prefibrotic MF. The myelofibrosis-free survival is considerably shortened and the curve stands out. So the type 1 CALR and the MPL for fibrosis-free survival, and the JAK2 for overall survival compared to the others. The JAK2 and MPL for overall survival were very equivalent. And similarly, you'll see that they are equivalent for thrombosis as well, which I'll review in the next slides. So how about leukemic transformation, which is a feared complications for patients with ET, because leukemia can develop even without going through the myelofibrosis phase. So it's very stressful for young patients to know that they could develop a secondary ML at any time point. So what are some of the predictors? So abnormal karyotype at diagnosis and extreme thrombocytosis was predictive of leukemic transformation. And it was particularly so in patients with the JAK2 mutation. So typically CALR mutated patients and triple negative have higher platelet counts. They are the ones who will generally have extreme thrombocytosis. But if a JAK2 mutated patient has extreme thrombocytosis, that is more concerning, that they may be at a higher risk. And then when we look at fibrotic progression, it's the MPL mutation, as we reviewed earlier, and an absolute neutrophil count greater than 8,000 were risk factors for myelofibrotic transformation. So looking at the thrombosis curves, we always like to distinguish between arterial and venous events, even though thrombosis sometimes gets lumped together, but we begin to realize over the years, these events are different, and the risk factors for each event is also different based on whether it's arterial or venous. For thrombosis, we know that JAK2 and MPL mutated patients have a higher risk compared to CALR mutated patients. The triple negative patients actually have the lowest risk. And once again, that kind of suggests that perhaps there may be some concerns about whether they are true ET cases or not. And for venous thrombosis, similarly, the JAK2 mutated patients have the higher risk compared to CALR mutated and triple negative patients, and MPL is equivalent to patients with JAK2. So what about the survival risk models? Because we know some of the mutation profiles that may predict survival like we reviewed, but simple parameters can help us manage our patients. So the IPSET survival model is over a decade old now. It considers leukocytosis and prior history of thrombosis as predictors of shortened survival. Then as mutational information has become available in the last 10 decades, in the last decade or so, 5 years or so, then we added additional parameters, particularly spliceosome mutations, and P53 mutation is very infrequent in ET patients, But if it is present prior to transformation, then you know the patients might be at increased risk for transformation and even leukemia. And male gender and leukocytosis. So the MIPS score actually incorporated both molecular features as well as clinical features. And among the clinical features, age above 60, which has been well known, and it was part of the IPSET as well, leukocytosis above 11,000, and male gender, and the spliceosome mutations SF3B1, SRSF2. And they were able to predict distinct survival differences into 4 risk categories. And you can see that the myelofibrosis-free survival was also predicted by the presence of spliceosome mutations, the U2F1 and SF3B mutations, and leukemia-free survival by presence of P53 mutations. And we know that these mutations do not occur very frequently, but we will only know about them if we test them. So it is advisable to kind of routinely run, at least at diagnosis and GS testing, if there are no issues with the coverage and if it's easily accessible. So moving away from molecular information, since molecular prognostication in ET is not quite incorporated into clinical practice, even in the US, for myelofibrosis, it's a different story where it's part of the transplant decision-making. And for ET patients, I think we do it on a case-by-case basis based on the discussion we have with the patients and the insurance coverage, of course. So how do we prognosticate the patients? So recently, this was developed at the Mayo, a very simple prognostic scoring system called the AAA score, which also considers age, the absolute neutrophil count, and absolute lymphocyte count. And as you can see here, the age categories here are different. Instead of above 60, they are like tiered, greater than 70 and between 50 and 70, rather than just above 60, because above 60 is also a big spectrum. And then the lymphopenia below 1.7 and absolute neutrophil count above 8,000 was able to nicely stratify patients into distinct categories, as can be seen here. So the low-risk patients have a median survival of up to 5 decades, and the high-risk patients a little less than a decade, suggesting that there's nice separation on the prognosis of these patients. So then, of course, whenever a new prognostic score gets developed, it needs to be compared to the pre-existing one. So it was compared to the IPSET model, which has existed over the decades. And we were able to show that it better stratified patients and it reclassified patients who were in the lower risk category into the higher risk categories and vice versa, suggesting its prediction ability was more accurate compared to the IPSET model. And I think these kind of look through the stratification of the patients. For example, IPSET high risk stratified by AAA, and you can see that, of course, a majority stayed high, but then some of them were downgraded to intermediate 1. Similarly, the intermediate risk patients stratified by AAA, several of them became high risk and intermediate 2, and some were even downgraded to low risk. And then the low risk patients, some were upgraded to intermediate 1, suggesting it had better discrimination in terms of ability to protect survival. So after the AAA was developed, then it was also applied to a larger data set. And here you can see it nicely separates out the low risk, intermediate, and high intermediate patients. And once again, it really helps you when you're counseling patients, because all the patients with ET are not the same, especially the younger patients. They have a lot of anxiety about a diagnosis of a chronic cancer. They're going to be living for decades with a disease that is potentially not curable with the current drug therapy. So it's nice to kind of review some of the data with them that for the low-risk patients, the 20-year survival is 80%. And of course, the higher-risk patients are also the older patients, since age is part of this model. So it kind of tells you that they are not the patients who are going to live for decades, regardless of whether they had ET or not. And then the additional risk factors are the male gender. We talked about that earlier. Arterial thrombosis as opposed to venous thrombosis and hypertension, which is also something that we would expect in the general population as well. So just to kind of summarize all the prognostic assessments on a slide here, since there's several prognostic assessments depending on what prognosis for which entity. So for thrombosis, we go by the IPSET thrombosis, and that has been revised as well about a decade ago, and it's become simpler: age, JAK2 mutation, and prior history of thrombosis. For the survival, there are several models to choose from. Of course, the simple ones are the ones that use just clinical data, And then, of course, if molecular information is known, then they can be fortified with combining the molecular variables if molecular mutations are present. And I think the best one, as I relate to you, is the AAA model, and all the data is available through the CBC testing. So what about karyotype in ET? And a lot of diseases, karyotype, particularly in acute leukemia, MDS, myelofibrosis, it's very prognostically relevant. So in ET patients, the karyotypic abnormalities are very few and far between, but it is important to obtain karyotype studies at the time of diagnosis, because if they are present, they have prognostic implications. We studied a large set of patients, and the majority of abnormalities were loss of chromosome Y, which is not really an abnormality because it can occur with aging, but about 4.8% of patients had abnormalities other than -Y, particularly 20q minus. And then we were able to see that the presence of mutations, particularly ASXL1, usually clusters with normal karyotype, and P53 with abnormal karyotype, as you would expect. So here you can see that the survival of patients with abnormal karyotype is inferior compared to patients with normal karyotype, whether you stratify the patients that are older or younger. So the curve on the left are patients above 60 years of age, and the one on the right is patients below 60 years of age. And in both patient categories, survival was inferior with abnormal karyotype. And we adjusted, of course, for the usual suspects, leukocytosis, male gender, and abnormal karyotype still remained an independent predictor. And it also remained significant when the spliceosome mutations and P53 mutation was added into the analysis, suggesting that it does have some independent prognostic relevance. So it's a good practice to obtain karyotype studies at the time of diagnosis. So a little bit more on thrombosis in ET, since that's the major complications patients with ET suffer from. So what are the predictors of thrombosis? There's arterial, which are the heart attacks, the strokes, the peripheral arterial disease, and then the venous events, which are DVTs, PEs, splanchnic thromboses, and cerebral venous thrombosis, which are very unique to patients with myeloproliferative neoplasms. So for arterial events, age, leukocytosis, presence of cardiovascular risk factors are known predictors, and prior history of arterial thrombosis. And for venous events, it's age, JAK2 mutation may be relevant for venous, and particularly there's some data that the VAF may matter. If it's above 50%, they may be at increased risk, and venous thrombosis history. And then the question becomes, where does extreme thrombocytosis fit in here? Because there's always concern when platelet count is above 1 million or 1.5 million on the part of the patient, as well as the treating physician, whether to lower the platelet count, specifically in low-risk patients who you otherwise wouldn't prescribe cytoreductive therapy. So extreme thrombocytosis was not a predictive of thrombosis or hemorrhage post-diagnosis, because with the acquired von Willebrand's, they can be concerned for hemorrhage tendency rather than thrombosis. So this is a difficult area to study because there are a percentage of patients with extreme thrombocytosis, particularly above 1.5 million, is less than 10%, even in the large data sets. And then if you look at the low-risk patients, the number of thrombotic or vascular events that they have are low. But we were able to study at least 27 low-risk patients with ET with extreme thrombocytosis and try to understand what kind of treatments they were on when they had thrombotic or hemorrhagic events. And this table really clarifies that the patients who had thrombosis, there were 2 out of the 27 patients who had major arterial thrombosis, and only one of them actually was not taking aspirin therapy. So it's suggesting that aspirin therapy, the omission of the aspirin therapy may have predisposed to that. Similarly, for venous thrombosis, the patient who had the venous event was on observation alone and was not on aspirin therapy. Similarly, the major hemorrhage occurred in one patient in the setting of acquired von Willebrand syndrome, and they were on observation, and another patient, they were on aspirin plus hydrea, and a major hemorrhage occurred. So this kind of suggests that putting them on cytoreduction may not necessarily be the answer to kind of lower the platelet count and reduce their risk for thrombosis or hemorrhage. So what's our general treatment approach in ET? So traditionally, we've classified patients into thrombotic risk categories, which has been very simple based on age and thrombosis history, which is a simple way of doing it. But then lately, we've been using the EPSET thrombosis, where we incorporate the JAK2 mutation information. So the very low risk patients are below 60 and are JAK2 unmutated. So if the young patients have a JAK2 mutation, we put them as low risk. The high risk patients are the ones who either had a thrombosis in the past or are older, above 60, with a JAK2 mutation. And then the remainder of the patients who are above 60 but without the JAK mutation, they are considered intermediate risk. So with this schema in mind, we make our treatment recommendations for the patients. So it's easy enough to remember. For example, if somebody has a thrombosis history, then we know they're high risk. Then you look at what kind of thrombosis did they have. Was it a venous event or was it an arterial event? If it was a venous event, then they need to be on systemic anticoagulation, and I typically keep them on indefinite anticoagulation because the ET is not going to go away. And then they need to be on cytoreductive therapy. Hydrea is the preferred cytoreductive therapy that we use as first line. And then if it's intolerance to Hydrea, then we may move on to interferon preparations. And then for the arterial patients, it is good to advise twice daily aspirin, and we'll go through the data which suggests twice daily might be better than once daily. And even in the patients who are on anticoagulation, if they have cardiovascular risk factors or JAK2 mutation, if there's no increased bleeding tendency, it is reasonable to do once daily aspirin, the baby aspirin 81 milligram daily. And then going to the low risk patients, the ones who are younger, below 60 years of age, it is good to look at their driver mutation profile. If they are JAK2 mutated, then aspirin twice daily. If they are unmutated, then are they CALR or MPL mutated, then should be on aspirin. But if they are triple negative or CALR type 2, then you might be okay with just observation, especially if there's no cardiovascular risk factors present, or at the most, aspirin once a day. The intermediate risk patients have always been tricky for me in my practice, particularly those who don't have the JAK mutation and who are just older, above 60. So typically aspirin twice daily, and I don't push them for cytoreductive therapy unless they really want to be on it because it's an equivocal decision. But if they are older and have the JAK2 mutation, then cytoreductive therapy is advised. So a few other points that I'll kind of review here. If we can't use Hydrea, then interferon is the preferred drug. In older patients, the old drug busulfan can be used to control platelet counts. We typically don't use anagrelide because of the side effect profile. It causes GI toxicity, it causes palpitations, and most patients are unable to tolerate the drug. And then ruxolitinib use in ET is sparingly. I usually only reserve it for patients who are having a lot of symptoms which are unexplained, and none of the other medicines have worked. So I typically don't use it in the first or second line setting. What about a patient with ET who has a high hematocrit above 45? We come across this quite a bit. Of course, look for secondary causes. For example, do they have concomitant sleep apnea? We can always treat easy things. But if it is not explainable, then it is best to do phlebotomy to keep the hematocrit below 45, like we do for PV patients, because JAK2 ET and PV are a continuum in terms of the disease spectrum. How about splanchnic or cerebral vein thrombosis? Of course, anticoagulation. The DOACs can be used instead of warfarin, or we can use low molecular weight heparin. And then consider adding aspirin if there are risk factors for arterial thrombosis. The use of cytoreductive therapy is quite controversial. It depends on the blood counts, because there may be some patients whose platelet counts are not very high. They're already in the normal range. The patients are more anemic. You could hold off on cytoreductive therapy. And then we also briefly talked about the management of extreme thrombocytosis, particularly in low-risk patients. There was no additional value of giving cytoreductive therapy just to treat the platelet count. So we recommend treating the patient and not the platelet count. Avoid the use of aspirin. If there is acquired von Willebrand syndrome, we check the ristocetin cofactor, and usually I use ristocetin below 25 as kind of the trigger point, and especially if they're having clinical epistaxis or easy bruising or bleeding tendency, to hold the aspirin therapy. So this is a new trial that was just published last month on aspirin once versus twice daily, and it was we need to congratulate these authors for running a difficult study, because ET patients have a long natural history, so it is difficult to track the significance in terms of reduction of bleeding and thrombosis. And pharmacologically, serum thromboxane B2 levels were lower in the twice daily versus once daily program. There was no major bleeding noted with twice daily. There was slightly increased non-major bleeding, which is okay. and major thrombosis was much lower in the twice daily group. And patients in the twice daily groups actually felt better in terms of microvascular symptoms, which patients with ET can often suffer from, headaches and, burning, tingling in the hands and feet. So the overall symptom scores were better with the twice daily program. So I think this kind of forms the evidence now for the use of twice daily aspirin in a subset of ET patients. And how about the use of ruxolitinib? It was not approved for ET, but we have it available for the related MPN, so it's easy to kind of use it off-label. So there's a clinical trial that's going on, the RuxoBeat study, Ruxo versus best available therapy in untreated or hydria-resistant intolerant ET. And as you can see, of course, the platelet counts are lower with Ruxo, the spleen is better, pruritus and concentration is better, but the CR rate was no different with Ruxo versus best available therapy. So we need to wait for more mature data and its approval if it is going to be approved for ET. And what we're most excited about is therapies that may be more biologically relevant and be able to eradicate the clone. So for CALR mutated MPN patients, a mutant CALR specific antibody has been developed by Incyte, which is currently in clinical trials and has actually started accruing in the United States and perhaps other parts of the world, such as Canada as well, which is promising in that it is very selective to the mutant CALR clone, and it is able to eradicate the CALR mutant MEGs as opposed to the JAK2 mutated MEGs or the normal MEGs. So there is hope that this will restore normal megakaryopoiesis, improve the platelet counts, but whether it is able to eradicate the disease is yet to be known because there could be many other players involved in the pathogenesis of MPNs. And I think I pivoted my talk here, but I am going to spend the last couple of slides on pregnancy in ET because there is a subset of young women with ET. Out of all the MPNs, a third of the young MPN patients are ET patients who are of childbearing age. And there's always a lot of anxiety on how successful the pregnancies are for these patients. So we just put together 200 pregnancies and 100 women. Live birth rate was 72%. And of course, the main complications were first trimester fetal loss in a quarter of patients. And the fetal complications were not very high, and neither were maternal complication rates. They were very reasonable. Of course, it's not a controlled study with the normal population, but if you look at the percentages, we didn't find any stark differences. In terms of the management, that is tricky because practices vary since there are no good guidelines or evidence. Aspirin itself reduced first trimester fetal loss in both JAK2 and CALR mutated patients. And then the predictors of pregnancy loss were prior fetal loss and diabetes mellitus, and aspirin was helpful and protective in both those subsets of patients, whether they had a history of prior fetal loss and diabetes or whether they didn't have one. The role of cytoreductive therapy in systemic anticoagulation was not generalized to all the pregnancies. I think there is a role for those treatments in a subset of women, but not just because an ET patient becomes pregnant that we prescribe them anticoagulation and cytoreduction. So patients had many different therapies, and actually 52 of the pregnancies were untreated because they were diagnosed during the pregnancy, the ET. So those patients had a much higher risk of pregnancy loss because they were not even on aspirin therapy since they didn't know that they had ET. So here's kind of a chart we put together. So based on risk for the patients, low risk, very low risk, and high risk. The high risk here is based on whether they've had prior thromboses or not. And of course, those are the patients where interferon is recommended since hydria is teratogenic. In terms of anticoagulation, low molecular weight heparin as opposed to Coumadin, which is also teratogenic. The role of DOACs is also questionable in pregnancy, so I haven't really used that for pregnant patient. And then when you come close to the delivery, the low molecular weight heparin needs to be held a day before delivery for the high-risk patients. Aspirin is typically held about 3 days before delivery, but sometimes the delivery is untimed and it happens emergently, and there may not be time to hold these therapies. Always check for von Willebrand's if patients have extreme thrombocytosis. The good thing is that in pregnancy, the platelet counts usually drop, particularly decline in each trimester in nadir and the third trimester. So when it comes close to delivery, even if patients had extreme thrombocytosis, that's typically normalized. And in case of recurrent fetal loss, it is reasonable to add interferon even in the low-risk patients because if there's been no good explanation why they've had a poor obstetric history, it is reasonable to assume that treating the ET better might with the pregnancy outcomes. So I'm just going to conclude with a few take-home messages. The main message is that there's going to be more coming in the space of prognostication and ET. I think the simplest prognostic model right now is the AAA model because it incorporates age, the ANC and the ALC, which is easily available in all parts of the world and is globally applicable. The role of mutation still needs refinement since the frequency of these mutations is quite low, specifically when you check them at the time of ET diagnosis as opposed to when they're closer to transformation. So we have to be careful about the time points in the literature as well. But it is going to emerge and perhaps be incorporated for more real-time practice. The role of aspirin twice daily has been clearly established through the ARIS study, particularly in JAK2 mutated patients without extreme thrombocytosis. And then, of course, there's a lot of promise with the mutant CALR antibody that it might have some disease-modifying potential. And over the years, we might be able to tell our ET patients that there is a potential cure and a drug which has anticlonal activity. But a lot needs to be known about it since the testing is quite early. But at least the phase 1 studies have initiated. So I will stop here and I'm happy to take questions and I'll stop sharing my screen as well.
Thank you, Dr. Gangat, for that wonderful presentation. You updated us quite a bit. Many new things you told us, and I'm sure that will help all of us. We'll have now questions. Dr. Aishwarya, your question.
Good evening, ma'am. Thank you for the wonderful talk. I wanted to know two things. Do you screen for 1 milligram in all the patients, or is there a specific group? And the second is low risk ET maintained on hydroxyurea. So, is there any platelet count we are targeting? Like, strictly, are we trying to keep it within the normal range, or it's like okay, 5-6 lakhs, 6.5 lakhs?
Okay, very good questions. I don't test all patients for acquired von Willebrand syndrome, only the patients with platelets above 1 million, or if they're having some bleeding tendencies, which are not being explained, if they're having a lot of epistaxis or easy bruising and I don't know what's going on, then I would check the ones with lower than 1 million too. But typically, routine screening is only for the over 1 million. And your second question about how stringent should the platelet count control be, I'm actually quite lenient with the patients. As long as they're taking aspirin, and specifically if they're taking it twice a day, and if the platelet counts are 500, I'm okay with it. I usually don't titrate the Hydrea too much because it is like chasing your tail. Then you have to keep checking weekly counts. If you up titrate, then you undershoot, overshoot. So I'm not a believer of really keeping the platelet count below 600 or below 450, and I'm more lenient. If they are on anticoagulation for some other reason, for example, older patients are taking it for AFib or something, so those I'm even more lenient because their Eliquis or their DOAC or whatever will cover the thrombosis reduction for ET as well. Okay.
Thank you, ma'am.
Thank you. Dr. Vishnu.
Yes. So actually, recently I have a patient with platelet count 25 lakh falls in low risk ET. So would you suggest cytoreduction at platelet count 25 lakh in patient with low risk or very low risk ET?
So another very good question. And as I emphasized in my presentation, we treat the patient, not the count. So if there's no bleeding tendency, I would let them be. If they are having epistaxis or, if there's acquired von Willebrand that is clinically relevant, then we need to treat, right, with cytoreduction to lower the counts and improve the bleeding tendency. I would just not give this patient aspirin, but would continue to observe.
And would you suggest like screening for acquired VWD because there is an inherent risk of very high risk of VWD with extreme thrombocytosis?
I think so. I would at least screen the patient, but I wouldn't treat just on the clinical lab value. I would correlate it with the clinical situation. But it's good to have the screening at least so you know what their baseline von Willebrand levels
are. One more question. So actually, I have a patient. We reported a patient. She was a young female, 16-year-old girl with iron deficiency anemia, platelet 25 lakh 57,000, reactive thrombocytosis 25 lakh 57,000. We ruled out ET by doing bone marrow. There was no clonal markers like JAK2, CALR, MPN. Everything was negative. So do you recommend antiplatelet in such patient like reactive thrombocytosis with platelet 25 lakh, 10 lakh, 15 lakh?
Actually, I haven't come across a reactive thrombocytosis with such high platelets. So that would be a first for me, but I wouldn't recommend because we know you made sure there's no clonal abnormality. So if the patients don't have clonal thrombocytosis, we are not at increased risk for thrombosis or bleeding or anything. So I would just watch it.
Thank you.
Thank you. Any other questions? Do you ever use double antiplatelet agents?
I have not, except if neurology puts them on it. If sometimes when patients have a stroke on aspirin, they put them on Plavix and aspirin, or they put them on a blood thinner plus that, then I would continue. But I have not personally recommended dual antiplatelet therapy. I think if you change the aspirin frequency to twice a day, because the platelet turnover in ET patients is different from normal platelets. So we feel like once a day is not enough to kind of reduce the cyclooxygenase and stuff. And that has been shown from the trial as well. The thromboxane B2 reduction was better with twice daily regimen. So I typically don't do dual antiplatelet therapy unless another specialty has put them on it, like the cardiologist for a stent or something.
Okay. Now, another question, if you had an arterial and venous event of thrombosis, then these patients will remain on antiplatelet and anticoagulant for lifelong?
Yes, they would remain on it for lifelong. Sometimes it's tricky in the older patients to continue both. So as long as they're staying on the anticoagulant, I'm okay with dropping the aspirin, especially if they're running into GI bleed or, some bleeding tendency, because it's not easy for older patients to be on both antiplatelet and anticoagulant. But definitely for those patients, you want to do baby aspirin once a day and not twice a day because they're already on an anticoagulant.
Question in the chat box from Dr. Kanan Ramamurthy. Kindly clarify on the prognosis of CALR type 1 and type 2 in ET and in prefibrotic myelofibrosis.
That's a very good question. So in ET, we know CALR mutated patients have a higher platelet count compared to JAK2 mutations. So in terms of thrombosis, the prognosis for these patients is better. The CALR mutated patients have a lower risk for thrombosis. But in terms of myelofibrosis, the type 1 CALR mutated patients have a higher risk for transformation to MF as opposed to the JAK2 mutated patients. And in terms of leukemic transformation, there is no difference. So I think there are some difference in the prognosis between type 1 and type 2 CALR. The distinctions are very minute. There might be a little bit of a lower risk of thrombosis with type 2 CALR, which is similar to triple negative compared to type 1 CALR. And then the risk for fibrotic transformation is lower with type 2 CALR compared to type 1 CALR. So yeah, there are nuances and differences. And now moving on to the prefibrotic MF, the type 1 CALR mutated have a better prognosis. So it same kind of applies like it does for primary myelofibrosis, where if patient has type 1 CALR, it's considered a good prognostic element in respect to survival. But I don't have the data for that for prefibrotic MF, but I would think that the ET data applies to the thrombosis in prefibrotic MF as well.
Thank you. Dr. Vishnu, you have another question? Probably not. Okay, in the chat box, there is a question about if you had to start cytoreductive therapy for a low-risk patient, when do you stop it?
So it depends why we are starting it for the low-risk patient. If we are starting it for a surgery, for perioperative management, even for low-risk patients, we'll often want to optimize the platelet count. I usually give them a short course of Hydrea, for about 4 to 6 weeks before the surgery, and then kind of keep them on it for about 4 to 6 weeks post-op. And along with the relevant, where depends on the procedure they've had, whether they need DVT prophylaxis or not. And so it's an interesting, I don't know what you mean by when can we stop it. We can stop it at any time. It depends on the indication for cytoreduction, because if it's a very low risk patient, you don't really need them to be on cytoreduction unless there is a particular situation that has occurred. And then, for example, if a young lady is pregnant and she's had a poor obstetric history in the past, and if there's a decision to start cytoreduction, then that would also be more like pregnancy focused, and then it could be taken away like postpartum, 6 weeks postpartum.
Dr. Hita has put a question of pediatric ET. Any difference in the treatment approach?
I don't treat pediatric patients, but I wouldn't think so. I think the same applies to pediatric patients too. But I don't have practical experience because the adult and peds hemonc here is a separate division altogether.
The question from Dr. Divya is, do you normalize the platelet count before surgery? And if yes, for minor surgery, major surgery, or for both?
That's another good one. The guidance for perioperative management is again very loose. We are mostly using our own experience rather than like evidence for these patients. For the major surgeries, definitely we shoot for platelet count below 450. And for the minor surgeries, it depends. If it's a cataract surgery or like a skin cancer removal, then I think we might even be okay without doing like hydria. You could just, because it's such a minor daycare procedure without increases for thrombosis in terms of immobilization. But if it's a hip replacement, if it's a knee surgery, where the patient's going to have other risk factors for thrombosis as well, we are pretty stringent. And if it's an elective surgery, we tell the surgeon to postpone the surgery if we are not there yet in terms of the platelet count.
Thank you. The question about the anticoagulants. Are the DOACs, warfarin, and LMW heparin equivalent?
Another good one. DOACs have been studied in MPN and they haven't been found to be inferior. There was actually a large study which was multi-center, published a few years ago, where they looked at DOACs versus vitamin K agonists. I personally prefer DOACs because warfarin is a very cumbersome. So I actually don't prescribe warfarin. The DOAC, the only limitation is the cost. I don't know about India, but here sometimes it's more costly for the patients, but we are finding out ways that there are some Canadian pharmacies that can give it at a much cheaper cost. So patients are able to buy it online. The low molecular weight heparin, we usually do when there's a new event. For example, somebody has like a new PE or a new DVT, then we start with the low molecular weight and then kind of transition them over. So it's a good one to use. For example, if a patient has new splanchnic thrombosis, I would start with like a low molecular weight heparin and then over the next 4 to 6 weeks, transition them to a DOAC. So I think those are the two I'm using. I'm not using a lot of warfarin. They've kind of phased away even in the AFib world. Patients are not taking too much Coumadin these days.
Thank you. The question about hydria versus interferon in young people with ET. Will hydria in long term be more leukemogenic?
And that's another very difficult question because the natural history studies are difficult to conduct. Hydria is used in sickle cell disease as well, where there's no concern for leukemogenicity in the young sickle cell patients. If I had to pick in a young patient, if it's a female patient who's childbearing, of course, we'd pick the interferon because, they may want to get pregnant at any point. Sometimes even the pregnancy is not planned. But for the older patients, definitely hydria is the first line. I usually don't pick interferon. And then we also look at the patient history. For interferons, the longer acting preparations are better tolerated, but if they have severe depression or if they have autoimmune disease, they may not be the preferred drug either. So I think a lot is on a case-by-case basis, but in general, young female, childbearing, if they need cytoreduction, doing interferon is advisable as opposed to hydria.
Question about pregnancy in ET. Young woman had one fetal loss first trimester. Now she's pregnant and otherwise it's a low-risk ET. What will be the management? Only aspirin or anything more?
I think it depends what the management was in the prior pregnancy. Were they already on aspirin in the prior pregnancy? Then I may be a little bit think about, what are the other causes. But if they were not taking aspirin, I would be very comfortable just keeping them on aspirin for this pregnancy and seeing how it goes.
Thank you. That's the last question in the chat box. Any question from anybody here? Okay, in that case, Dr. Nasima Ganga, thank you very much for sparing your very valuable time. It was a real update on this disease. One question has come up in the chat box. Triple negative ET. Do you recommend assessment of myeloid neoplasm associated genes? And if it has, and does it have any implication on prognosis?
I think that is a very important question, and there's research going on in that domain. I think it is advisable to at least establish a clone through more molecular testing. So I would like to do an NGS on these patients to see if there's other myeloid-associated mutations. I don't know about its implications on prognosis yet. So I think that needs to be determined because these patients still need to be systematically assessed and studied. So triple negative ET is another area which needs more study because, as you know, these patients fare better compared to the patients with driver mutation. And we still don't quite know, were they truly ET patients? Were there some element of reactive thrombocytosis? So this will be an area where I think you're going to see more literature emerge.
Thank you. The same came back the concluding remarks. Thank you very much for sparing your time. Whenever you have spoken to us, we have learned something, and I'm sure you will be with us for future educational sessions as well. Thank you so much.
Thank you. Thank you for having me. Have a good evening. Bye.